Welcome to the first East Midlands Home Oxygen Service Smoking and Fire Safety webinar. We are now going to make a start. There will be some people still coming, but we need to make a prompt start because it's going to last you 90 minutes, this webinar is. It is being recorded as well, so just to let you know that it will be available afterwards. Okay, so we're going to do some introductions first of all, and then we'll go on to the agenda afterwards. So my name is Julie Owens, and I'm the Respiratory Advisor for BOC in the East Midlands. And next is Dr. James Booth, if you'd like to introduce yourself.
Hi, I'm James Booth. I'm a GP in Chelmsford. I'm also the safeguarding GP for our local area in Mid-Essex.
Hi everyone, I'm Claire Murphy. I'm the clinical lead for BOC.
Good morning everybody, I'm Niall Farrell. I am the Operations Manager for BOC in the East Midlands.
And finally, Josh Charlesworth.
My name is Josh. I'm an Operational Watch Manager from Derbyshire Fire Service, but I'm also a Risk Reduction Manager.
Thank you, Josh, thank you. We're ready for the next slide, Claire. Thank you. So we're going to move on to the agenda now. So, why are we here this morning? We're looking at, first of all, we're going to be looking at managing a CIRI and a case study of a real life patient. For those of you who don't know who are new to the acronym CIRI, it stands for Serious Incident Requiring Investigation. And these are shared with the CCGs for best practice. And then Niall's going to be talking about the benefits of smoking cessation. Claire's going to be talking about the benefits of smoking cessation and smoking policy. And then Niall's going to be talking to us about e-cigarettes and the dangers for our patients in the home. And then finally, we have Josh, who will be talking to us about home fire safety visits and collaborative working with the fire and rescue service. Some food for thought here really about some data. This data actually dates back to 2018, but it's still relevant today really. And this is looking at fatalities that are basically caused by oxygen in the home. So if you look at the first slide here, we've got the US. They've got about 1.5 million patients who are on home oxygen, and they have about 100 fatalities every year. And that equates to 6.6 fatalities per 100,000 patients. And similarly with Japan, they've got 160,000 patients who are on oxygen, and again 5 fatalities every year. And that equates to 3.3 per 100,000 patients. And England, as you can see, we're doing an awful lot better. We have 81,000 patients on home oxygen, with a third of a patient per 100,000 patients who die because of home oxygen and a fatality with a fire. So although we're doing better than the other countries, one patient is still too many. So the things that we do, I'm not quite sure what they do in the US and in Japan, but the first thing obviously is the risk mitigation tool. This came out at the same time as the East Midlands Risk Mitigation Tool. And the East Midlands Risk Mitigation Tool, the MHAWT, came out on the back of a fatality that happened in Lincolnshire. And it was one of the things that the coroner brought up was, well, what is done to try and prevent these from happening? So that came out, and that is done for every single patient before you even consider having oxygen installed. And then obviously when the home care technicians go in and install the oxygen equipment, they will then do an education and risk assessment at the patient's home. On top of that, we also have fire breaks at BOC, and these were first produced by BOC, and they will help prevent fires from spreading. So if a fire did occur, there's a little device inside the fire break that will melt if it gets hot, and that will occlude the oxygen from tracking up towards the patient. And also we obviously have a multidisciplinary collaboration, shared safety learning. So we have meetings with the CCG and CIRI meetings every single month, and clinicians are come to that as well. Thank you, Claire. So I'm just going to hand over to Claire Murphy first of all, and she's just going to give us a little bit of background about this case study, and then Dr. Booth will then continue with the case study. Thank you, Claire.
Well, I think after the figures that you've just been hearing from Julie, it looks like we're in quite a good position over here with less fatalities than the other countries. But what you're about to have presented to you is actually we're in a quite a fragile situation where week on week, month on month, we're dealing with patients with facial burns, so smoking injuries, smoking on oxygen injuries that we're having to try and lessen the risk and breathe a sigh of relief that actually it wasn't a fatality. So whilst the figures look quite good, we're actually fighting the big fight day on day, week on week, and we need your collaboration to do this as well. So this particular series occurred on the 24th of October last year. Now, unbeknown to us on the first date when it happened, a patient woke up, saw that his tubing was on fire and that this fire had spread to his trousers and his shoes. He shouted to his brother, and his brother came in and put the fire out and called an ambulance. The patient was then taken to hospital with facial burns. But there was no idea what caused the ignition. The patient did have television and air conditioning in his room, but the patient had said to the ambulance crew that no one in the property smoked. The A&E department looked at his wounds and then sent him home. So BOC knew nothing about this. On 2 days later, the patient called us to request that his tubing was replaced for the concentrator. And he mentioned in the conversation, as all of our calls are recorded, that there had been a fire. So immediately we raised a SIRI, and this was then escalated to include the fire service and everyone involved in the patient's care to find out what happened and how we can prevent this happening again and a potential fatality. So our technicians attended the property and found no sign of smoking. There was a lighter there was a toaster, there was no smell of smoke, there was a microwave and an oven in the room that the patient slept in with his oxygen. The patient was given lots of safety education and still said he didn't smoke at this point. Another 48 hours later, we did a further follow-up visit. And the patient repeated again, this was a different technician, that he did not smoke. But at this point, the patient reported that he had an alter ego that was trying to kill him. So the technician immediately escalated this to myself, and we already have a SIRI running with this. And I then knew that this was much more complex, and I contacted Dr. Booth, the patient's GP, and the oxygen respiratory nurse to request an urgent MDT. And at that point, I was looking for possible removal of oxygen or to try and work out what is the safest plan to safeguard the patient, the brother, and everyone else involved in the patient's care, really. 48 hours after that, Dr. Booth has visited the patient, and actually the burns had deteriorated. So he was seen in A&E initially 6 days earlier, and then the burns were worse. So at that point, Dr. Booth put a removal hoof in and actually requested the patient go back into hospital to have his burns managed. And we could have time then to organise an MDT. And now I would like to hand over. We're very lucky to have Dr. Booth joining us, and he'll join us just to present his session and then have to leave, sadly. Over to you, Dr. Booth.
Thank you very much. So yes, this was a really interesting case, something I'd never come across before. And this is a gentleman with a very unusual clinical circumstance. The only patient I've looked after who actually had a confirmed dissociative personality disorder, or effectively a split personality, as you see in films, and a really interesting implication for patient safety. So this gentleman was a 56-year-old man and not a well man at all. Lots and lots of chronic health problems. So he had chronic obstructive pulmonary disease, which had put him to the point of type 2 respiratory failure, hence the need for his oxygen. And he was completely oxygen dependent at home. He got very unwell if you took him off his oxygen for even a small period of time. He also had heart disease. He was a diabetic. and a very significant mental health history, although his mental health history had always been a diagnosis around severe depression. And he'd had a couple of inpatient stays in his time, almost completely housebound, very poor mobility, and lived with his brother, who was also a rather vulnerable adult as well. His brother had very significant mental health issues. In fact, his brother's mental health issues, if anything, were worse than our patients. And his brother's mother-in-law, slightly unusually, lived with him as well, who was a rather frail lady in her 80s. Quite a challenging house to visit sometimes, quite cluttered, lots of eccentricities around their presentation, but a little unit we knew quite well, actually. I used to see him and his brother, I'm seeing him a couple of times a quarter. They were regular patients. So I could just have the next slide. So as Claire's recounted, he on the 24th of October, he calls an ambulance because his oxygen tubing catches fire and burns his face. And he can't account for the cause of the fire. And as you can see, there is this this idea that while he's an inpatient, he says, "I think my split personality has tried to kill me." And he actually then tells people for the first time, really, that he has this split personality who he has a name for, he calls Edward, who has been present in his life since his teens. He's never really told anybody about this. His brother knows about it. And he doesn't like me, he's tried to kill me. He said that when he's not under the effect of this dissociated personality, he's completely safe around his oxygen, doesn't smoke, and we'd actually never had any concerns about oxygen safety with him before. And the hospital don't really do very much with this, so he's discharged home fairly quickly, and there's this idea that he'll have some community mental health follow-up, but there's no safety assessment, no plan around his oxygen. And in fact, the sort of weird history is kind of dismissed. So then I come into the story when I speak to Claire, and I absolutely agree. This is something really unprecedented. It seems very unsafe. Whatever's happened, and I wasn't entirely sure that whether this diagnosis was there or not. This is so dissociative personality disorders are properly rare. They're much more common in fiction than they are in real life. And in fact, I have to confess, my first supposition was he's been caught out having had a crafty fag, and he said this because he doesn't want to admit that he's been smoking. So perhaps rather unfairly on my part. I'm aware that a lot of my patients on home oxygen do it despite our advice, try and have a cheeky fag. But he absolutely needs to go back in. Because he's oxygen dependent, he can't be at home, and there's obviously the safety issue as well. He's very, very unhappy to be readmitted. And what happens at this point is something that carries on with his hospital presentation, is that he feels that healthcare, me and BOC in particular, are being very unfair, making him go back into hospital. He believes that he shouldn't be there. He hates being in hospital. He finds it a really difficult environment. And the whole time he's in hospital having his burns sorted, which actually didn't need very much care. And some of his chronic health conditions needed a bit of sorting out. He is spending his whole time saying, "I hate being in hospital. I really, really want to go home." What happens then is that lots of different teams become involved with him. So he's under our local palliative care team, and his social worker are very, very keen to highlight that he would rather go home without oxygen than go to a care home, which is one of the settings that's being considered for him to keep him safe. And what is really challenging about this actually is that he gets the mental health team do come and see him and do absolutely confirm his diagnosis. So, this is properly weird, but this man does genuinely have a split personality. And it turned out that it stemmed from some really awful trauma in his teens. And he'd actually been carrying this as a feature, and it almost has been hidden in plain sight with the rest of his illness. Actually, he'd been having mental health support all his life, but this element of his very complex condition had never really come out. What's what's challenging though is that a lot of the teams looking after him have a surprisingly adversarial view about he should be allowed home. Patient autonomy is very important. He wants to go home. You're being very cruel almost to keep him in hospital. I had an email sent to me by his social worker accusing me of having given him an ultimatum, which she felt was very unfair. You know, you've got to go into hospital, your oxygen will be removed forever, this sort of thing. It was, and lots of really surprising amounts of emotion expressed in these things. And this big conflict between a man who had capacity, had a very deeply held wish to return home, but also couldn't return home without his oxygen, because had he gone home without it, he'd have been back into hospital within hours. And this big uncertainty about, is he safe? And this big debate on the team between people saying, we absolutely want to get this man home, being in hospital is bad for his mental health, he wants to go home, he's got capacity. And really, it was just me and Claire saying, no, this is terribly unsafe. There's been a fire around his oxygen. We still don't really know what's happened here. So if I could just have the next slide, that'd be great. So we had an MDT, so almost exactly a year ago now, and a really challenging discussion, actually. A huge amount of tension between the emotional well-being issues for our patients and the safety issues. And I have to say, having done an awful lot of MDTs in my time, I was really surprised by actually how difficult some of these conversations got. And there was actually quite a lot of, the other thing that surprised me was sort of support by professionals who some frankly completely outlandish ideas to keep him safe. So genuinely, one of the proposals that he and his brother had come up with to get him home was that they were going to tie him up at night. They had a plan for securing him arms and feet to his chair, so if his split personality emerged, he couldn't go and set himself on fire. And this was actually genuinely given as a mitigation by one of his healthcare workers as well. They think we can do this, or we can have a pressure pad, so if he gets up, his brother will be woken up. There'd been some misconceptions, so people have been willing to put in emails and formally state that the fire service had said that he was completely safe at home, which the fire service then had to correct and say, well, no, we haven't said that at all. And ultimately, we finished this rather difficult meeting where absolutely we need to have some further planning and a real sense of having to try and move away from this very emotive conversation about and get down to the unarguable facts about his safety. And it actually culminated at one point with me saying, all of us want the right thing for this man here, but we also need to be aware that if he goes home and there's a fire and fatality, we're going to be discussing this in front of the coroner. And I don't think there was a sense actually that the actual safety issue wasn't really being recognised by people. So fortunately, we had a second MDT a week later. This time now, there's a much more detailed risk assessment drawn up. And he has a really robust care package put in place, and he's got actual overnight resident care at home, which isn't very easy to get on the NHS, but we managed to, his team managed to get it for him. And some community mental health follow-up plan. The mental health team changed his medication a bit. And there was this very much sense of, we're going to get you home on a trial basis. But the fundamental thing actually was you're not going to be alone at night. There's going to be a carer in the house with you to monitor things. And also a sense that we have this new diagnosis we want to monitor as well. But he was in hospital for another week and rather unhappy about it. But we did manage to get him home. And I'm going to have the next slide. And actually, in fact, this slide has become out of date in just the last few weeks because, in fact, my patient passed away very recently. But he passed away at home, and it was very much an expected passing for him. And he managed to pass with his brother and his little family unit around him. And we didn't have any further incidents. In fact, his care package never got pulled from him. And that was my big worry, was that we would be back to square one if his care, because the mental health follow-up, to be fair, didn't really happen. But in fact, he had a lot of supportive care throughout the rest of his life, and had actually the easiest passing he could have had given his conditions. This was a really unusual case. I'd never come across anything like this in my 15 years as a GP, and there were so many learning points from it, and I've raised these locally as well, which was the absolute importance of teamwork here. It was really, really valuable that clear communication between all professionals involved was absolutely essential. And it didn't really happen the first time we went into hospital and bounced out again. But the fact that, and played an awful lot of the coordinating of that communication, the fact that we were able to speak, we were able to meet twice about him, it was time consuming and difficult to organise, but it was absolutely vital. And I think the unexpected levels of conflict between wanting to advocate for a patient, as we all do, but this absolutely empirical fire safety risk. And it was surprising to me how much the latter got trumped by the former. And there was this sense of our paramount thing here is him feeling happy, rather than our paramount thing being he's got to be safe, as have his neighbours. And I think it also showed that there were some teams, and professional teams, who didn't really get the oxygen risk. I think in particular the palliative care team, the counselling service, who have healthcare counsellors, didn't grasp what she wants.
Could everybody apart from Dr. Booth go on mute?
The other thing, and this is something I take from my other job, is I'm the child protection GP for Chelmsford. And one of the things that I bring out in child protection training for GPs and practice nurses is this idea that you have to balance trusting optimism, which is our default in the NHS. We want to believe our patients, we want to be optimistic for them, we want to, you want to listen to what patients say and take it at face value. But that has to be balanced against sometimes a respectful skepticism of there are sometimes patient stories get confused, patients' agendas may be very different to what we would want for them. And actually that balance was really important here, actually, that on the trusting optimist view was this chap saying, this is a complete one-off, it will never happen again. And actually having to challenge that and to say, you don't know that, this has happened, there's been a fire, we can't, we've got to keep you safe, and keeping you safe might mean doing things that you don't particularly want us to do. All of us, everybody involved, had information that only we knew about that we needed to share. And that was really important as well. And again, I think it was a very full MDT, but I think actually everyone being part of that was really important. And what it also meant was that everyone could take the final decision, everyone was taking ownership of it. It felt that as things went on, it really did feel like the whole team had made a decision about him. It took a while. It took a while to organise. He was in hospital for a fortnight, and that was during a COVID pandemic when he was at risk. And he was very worried about catching COVID. And of course, we couldn't do anything to say. He was in a side room. Everything that could be done in the hospital to stop him getting it was done, and he didn't. But he absolutely was in a risky situation in hospital as well. And I think that was probably informing a lot of the thinking here as well. I actually think it was organised absolutely as quickly as it could have been, given the number of people involved. But that was still quite a while for him. And this is more of a NHS thing than our other agencies here, but he had a failed discharge, which we never like. He very nearly had 2 failed discharges, because had he gone home the second time, he'd have bounced straight back in, because I'd have gone round and tried to admit him again. So, and that's not great for a vulnerable patient. You don't, failed discharges are never good. We always want to avoid them because they're bad for patients, bad for health services, bad all around. But it became a really, really good example of team working in the end. And it was really good, actually, how a lot of very conflicting views sort of got synthesized into a safe plan for this chap. It was probably the best attended MDT I've been to in the last few years, with everybody. And I think partly, if I'm being completely honest, some of that was because it was interesting. And because this was a bit weird and unusual, that does help get people to meetings. But it was a very, very well attended, lots of people wanting to be involved. And actually, I think after the first rather fractious meeting, the second meeting was much more balanced and much more sensible. And also, and this was a learning point for me, I had no idea that BOC, rather to my shame, I had no idea BOC had the clinical advisory resource that it has. And I think in common with most GPs, I thought BOC was just somebody you sent a form to and a technician came out. And actually having Claire's expertise and the knowledge of actually how much of a detailed process there was behind this, that's been something that I've been telling everybody about. And I don't think I'll have another situation like this, because I think he was a once in a career thing. But actually, that safety resource, I suspect not nearly enough people in the NHS know about it. And that was a fantastic thing to have. And actually, certainly, it was really good to have Claire's voice at our meetings, being really, really supportive about the sort of the empirical safety risk and presenting that in a very knowledgeable way, with very, very clearly and very unarguably. And I think without that, we could potentially have had a very different outcome for this chap. So yes, so that's the story of our split personality in Inspire.
Thank you so much. That was really interesting, and I'm sure that we're going to have lots of questions for you, Dr. Booth. If anybody's got any questions, do you want to put it in the chat or to raise your hand?
I'm going to raise mine.
Okay, so we have, sorry, just bear with me. Oh.
I can see Julie.
Sorry,
Wendy,
I can't see, sorry.
no, it's fine.
Yeah.
Wendy, do you want to go first?
It's not a question, it is actually just to say, I think until us in Oxygen know this is a risk, and we spend most days having these conversations about the risk of fire, smoking and everything. And I think until somebody who's not directly involved in Oxygen every day has to live through it, because I think they do think you are being mean, if you're threatening to remove somebody's oxygen. But it is about them understanding. So I think there's a lot of learning that needs to be out there for outside of the oxygen services and the oxygen providers, because I think until you've actually lived through it, you don't realise how difficult that situation is. And as oxygen services, we live that every day. So well done for a good piece of work, but again, it is very challenging.
Thank you, Wendy.
Thank you.
Eleanor, do you want to ask a question?
Yeah, sure. It was basically just to ask, really, if the other clinical teams, do you have access to carbon monoxide monitors to sort of test, you know, like Joe, from the smoking point of view, if we can never guarantee if somebody's smoking or not, do other teams use carbon monoxide monitors to actually test those patients?
Well, we do in our smoking cessation service, actually. So we've got one. In fact, I don't know about the hospital. And I suspect they probably don't. They might have one in the respiratory clinic, but we use them. We don't use them in this context. It's really much more it's often as a progress measure when you're quitting smoking. So we had one we could have used on him, but I think it was and I think it was something I felt slightly guilty about. Was my initial response actually was, oh, he's been fibbing, he's just been smoking and hasn't told me. So it's a good point actually, and it didn't occur to me to take RCO monitor around to his and put it on him.
Yeah, because we've had access to a few over the years. I think they all need updating now. But like if we, like you say, it's quite a good thing that I think I've sort of recommended that we do routinely. So to ensure that somebody isn't smoking, doing that general baseline as part of the assessment might be quite a useful
Yeah.
tool.
Well, I mean, I can see actually a value in doing that when we review COPD patients at home all the time. And actually, that's not part of our assessment. But I'm wondering now, that's something I'm going to take away from this, actually. I'm wondering if it should be.
Linny, you've got your hand up.
Yeah, I mean, that was really fascinating. Thanks for sharing that with us. And it just shows just how diverse these cases can be, doesn't it? And how rare they can be. I was just wondering, when you say you'd set up some overnight care for him post discharge, I know he's sadly passed away now, bless him, but your presentation said that it was just going to be in the immediate post discharge phase. So
It never stopped in the end.
Okay.
Which was, and to be honest, I had a couple of conversations with the social worker saying I just think it needs to continue, and I think actually the unusual circumstances probably helped because there wasn't really an option to remove it. It was, and I think actually, I'm not sure had there been a possible risk, I suspect it would have been quite hard to get. But we were actually always able to point to the fact that there had been a fire. And much as one would, of course, wish there'd never been one, it did mean that you weren't talking about a theoretical risk. You were able to say, you know, it's happened once, it'll happen again. And I think that probably did help those conversations.
Okay. It wasn't through the hospice then, you said it was NHS, wasn't it? And
yeah,
right.
No, it wasn't through the hospice.
Okay, thank you.
Thanks, Linny. Catherine Watson, you have a question?
Not so much a question, just to echo really in terms of what James has just said. As you'll be aware, Julie and Claire, we had a very interesting removal out on the East Coast fairly recently, and as a clinician, the support from BOC was amazing, and it made the whole difficult process so much easier to know that we've got your obviously support in the removal and that sort of backup support, even to the fact that I think it was Niall yourself, you rang me on the day we did the removal, as I've been called evil and many things, but you actually rang me in the afternoon after the removal to actually see how I was as a clinician, and that it goes a long way. And I just want to encourage people, you know, as unpleasant as the conversations are and where we get into these most difficult situations really, and I wish James that I'd got the support of GP on board as well, because I actually had to go to secondary care to get sort of clinician authorization really for, you know, making sure that we weren't had to go to secondary care, and it was a consultant, just needed a rubber stamp really. We were taking LTOT out, so you feel like you really are compromising this situation, but BOC support was, and local team support was really good.
Thank you.
Thank you. Thanks, Catherine. Is there any more questions? No? Okay, well, thank you so much, Dr. Booth, for sharing that with us. It's been amazing. And
thank you so much. Thank you so much for asking me along. And as I said, I hadn't been aware that all this work was happening, rather to my shame. So it's such a useful resource that I think many, many more people in my position should know about. So forgive me for leaving now. COVID is wreaking havoc. We have people off with COVID here. So I'm going to have to crack on, but thank you all very, very much again for the invite. Yeah, it's been a very, very interesting case, this one.
Thank you.
Thank you. So I'm going to hand over to Claire now, who is going to have a chat with us about the benefits of a smoking policy for our home oxygen. Thank you, Claire.
So leading on from actually what we've just been talking about, how do we change the cycle? Yesterday I was pulling together figures for the last 3 months with smoking injuries. Every single case, and there's been probably about 2 a month that we've had in each region, the patient hasn't been the one to say that they've burnt themselves. It's always been through another party. So we need to be able to make some changes because, I feel like we're close to further fatalities until we get to a better point. At the moment, what we can see is sort of headline things. So our technicians really are our eyes and ears on the ground. So they will report things like they smelt smoke in the patient's home during a visit. It could be a replenishment of cylinders or whatever, but they're detecting all the time. They may observe a lighter seen on the patient's bed. These are actually all facts. A full ashtray in the patient's lounge. Yellow stained curtain and walls in a patient's home, or recently we've had a spate of increased drug dependency, so patients who've been smoking heroin, which of course is going to affect their cognition and ability to make wise decisions and not remove their oxygen for 20 minutes before igniting, alongside having drug issues as well. And then also we've got the other end from heroin to cannabis smoking. So in the east of England, different CCGs have started to create a smoking policy. So this is our kind of tool for clinicians to be able to have a policy to say, actually, this doesn't fit in the policy, so we can't install oxygen. The aim, what we want to get to in the East, is that we can look at all the policies that have been created and then have one for the region. And I would suggest for East Midlands, this would be the same, because I think that you may have a couple, but how rigorously are they followed? So the policy should provide clarity and backup for you. So you would know what to do if you've got a known smoker, and whether this is e-cigarettes or actual cigarettes. What's the next steps for them? So do they have to join smoking cessation, and then you would review them after 3 months? Things like that will be powerful tools for you to follow. But also in the policy, we want to have a good position for us when there's a patient in hospital who needs to be discharged with oxygen. Because in my experience, that's where we can really feel the pressure, and it's far more complex. When you've got a patient who's medically fit for discharge but just can't be weaned from oxygen, and there's safety issues, that pressure of the bed, and if you can't organise a step down bed either, is really great. So the policy needs to incorporate all different scenarios to be fit for purpose for us. It also should cover other smokers in the household, but smokers people that start smoking whilst on the oxygen, palliative patients as well. I'm really trying to target GP surgeries who would probably do more of the palliative prescribing as to when those safety risks are there, when not to do it, when to be extra cautious and not put the oxygen in, especially when it's not indicated, I suppose, at least 50% of the time. What's the definition of when someone stops smoking? Where's the evidence around it? And also we've had a couple of cases where patients have been admitted to hospital, and the proposal from the hospital is that admission should be included in the smoke-free period. Now, is that fair, or is that a forced environment? So all of these things need to be thrashed out in a really robust policy. And also then, who's the ultimate decision maker when there's conflicting views? Dr. Booth presented to you about the MDTs. The first MDT for that particular case was probably the most volatile, emotive MDT I've been a part of, and that's from healthcare professionals. So who has the final decision? I know that we can put our foot firmly down, but we want to work in collaboration. And also, when is an MDT required? I think you'll find more and more with Julie and with myself that we ask for an MDT because it's a safer, holistic discussion and a way to move things forward. So for the future, I would propose that we look at the policy, we share across the regions, and for you all to think about what you need to see in your policy and get something created. Thank you, Claire. But what are we doing? So I'm involved with the policies, creating them, reviewing them, but also for our technicians. So you've seen I've said that there are eyes and ears. They also have a rapport with patients. So although patients in East Midlands now have a group of technicians that they will be familiar with, they will be familiar with them. They'll know them after a period of time, regular faces. So we're utilising the ability of that kind of contact without them being a healthcare professional to do something called make every contact count. So we've done this successfully in the East, where our technicians have had additional training from our smoke-free partners, and they now have the ability to give very brief advice on smoking cessation. So it's understanding current and past smoking behaviour, highlighting the impact of smoking cessation. You know, you've got those patients who I've tried to stop smoking before, it didn't work. Well, what can we do that's different this time, rather than, okay, fair enough, and then just leaving it at that. So we're trying to be really proactive with our health education message, and that's collaborative with Smoke Free in East of England and One Life Suffolk. So we'd like to do the same in East Midlands. So our ears and eyes on the ground, our technicians are skilled to do even more to support us in our plight for safety within the home. Thank you, Claire.
Thank you, Claire. Does anybody have any questions? If you'd like to raise your hands.
I mean, it might be quite good at a later date for any of you to say, well, actually, we've got a policy, but then if you've got a policy, let's look at it and then see where is it not working, or how does it work for you, or is it time to freshen it up? Is it time to discuss as a region-wide? Linny.
Hi, I nearly forgot to unmute then. Yeah, is it worth putting on the agenda for the next meeting and just all pull together what we already have and just have a discussion around it?
Me and Julie are having a look at what's on the agenda for this month's meeting, so we'll see. I'll see what we can juggle things around, Linny.
Okay, lovely. Can I just say as well, I think it's half-term week, that meeting, so I don't know how you're going to go on for attendees. I am able to make it, but
okay,
it's 26th of October, isn't it?
It is, yeah. Is it worth? When is? Because some areas have 1 and some have 2 weeks. So do I push it back to the first week in November? Do you reckon, Linny?
I'm not.
I only have a cat to worry about. He don't go to school, so
not anymore. Well, it depends when the 2 weeks are, because I'm Lincolnshire. I'm not Nottinghamshire schools. So if somebody can advise when the Nottinghamshire 2 weeks are, then I do think it's better, because it will. I think it will mean last 2 weeks of October. Thanks, Bryony. So yeah, first week in November might be better.
Right. Julie.
Nottinghamshire half term starts on the 25th. The 18th, sorry.
Okay.
Thank you, Linny.
So if we move it back to the first week in November, then we're back. Then everybody's back from half term, yeah.
Yeah, I think that's better. Yeah.
Julie, we're meeting tomorrow, so we'll add that. Just remind me. I'm writing the list.
Thank you. Is there any more questions for Claire? No, okay, that's fine. Well, we'll have a chat about that on Friday, and we'll come up with something and put an agenda together for.
Actually, sorry, Julie, can I just ask
sorry,
Claire? Yeah. On the back of this, Claire, I've had an email this morning from someone we've obviously got the MOT that we use in East Midlands as our risk mitigation. It's quite a few years old now, and it probably does need reviewing. This is probably something that we need to do some joint working on, because look at it together and see how we can actually sort of beef it out with some of what we're discussing today, Claire. Yeah. Is that something you'd have to get involved with?
Yeah, no, definitely. Just by the by, I've been doing the GP training. So the last 2 sessions, in the East we use the iHorn, so it's more of a basic form. When I've asked the GPs what do they know of the iHorn, they haven't got a clue what it is.
Yeah.
But probably everyone's not surprised by that.
Thanks, Claire.
Okay, thank you. Thanks, Claire. So we're going to move on now, and Niall is going to chat to us about the awareness and safety training, and particularly looking at e-cigarettes. So over to you, Niall. Thank you.
Good morning, everyone. As previously mentioned, I'm Niall. I'm the operations manager for the BOC in the East Midlands. I have a team of around 25 technicians. We're out and about in the local community, and one of our key things is community safety and patient safety. It is one of the biggest things that we're interested in, as well as delivering a good service. As a lot of familiar faces here today know, how keen I am to work in partnership with you guys, and yeah. We'll touch on it later. We have only been in the region for a year, but we're growing a really good relationship with a lot of the local fire services. And that's really exciting. They've certainly been a really good voice for us in MDTs when I worked in the East, as far as that delivering that safety rationale. So I'm looking forward to a bit more about that. But at the moment, I'm just here to talk to you about e-cigarettes and some of the risks that you may not have known about. So e-cigarettes themselves, they can be a helpful tool in aiding with smoking cessation. And due to a lack of a naked flame or lack of ash drop, they're certainly safer, but they aren't risk-free. And this is even more exaggerated when it comes to a home oxygen service patient. So in the UK at the moment, there's around 2.9 million adults in Great Britain that use e-cigarettes, and of these, 1.5 million have been able to completely stop smoking. Like I said, they do carry a fraction of the risk, but if we carry on, Claire, I'm going to talk to you a bit more about some of the ingredients and why they could be more dangerous. There's a word on here I'm going to struggle to say in a moment. I forgot to bring my glass of water as well. But e-liquid, also known as e-juice, is the substance that's inserted into a vape or a vape pen. It gives the vapor its flavour and nicotine. When the vape pen is in use, a battery will provide energy to heat up the e-liquid, turning it into a vapor. There's 3 core ingredients to that liquid. The first one is propylene glycol, and that's made from 2 alcohol groups. It has an auto-ignition temperature of around 371 degrees C, which is a temperature we need to remember just for later on. Vegetable glycerine. So any glycerine is a type of sugar-based alcohol, and that's normally derived from animal products, plants, or petroleum. That has an auto-ignition temperature of around 400 degrees C. And nicotine is it's a potent parasympathomimic alkaloid. So for those of you that don't know, the parasympathetic nervous system, that predominates in the quiet, rest and digest sort of condition, and the sympathetic nervous system drives the fight or flight response to a stressful situation. So the main purpose of the PNS, the parasympathetic nervous system, is to conserve your energy and relax you. So when someone's getting that nicotine hit, it's relaxing them. It is a drug. It is chilling that person out, and it is addictive. Thanks, Claire. As you can see, e-cigarettes come in many shapes and sizes, and it's really important for both yourselves as clinicians and the BOC technicians to be really vigilant when risk assessing patients. And as you can see, they range from, the hyper realistic to like the pipe and the cigar looking one over there, to something that could be disguised as a pen. So certainly when we're doing our dynamic risk assessments, we're not afraid to ask the question, is that an e-cigarette? And really, for me, that vigilance is key, and that should be across the board, like when clinicians are assessing it, as well as the BOC technicians. I'm not going to spend too much time going into the details of an e-cigarette. There's 2 main components really that we need to be concerned with. One is the battery, which obviously provides a charge, and the other is the coil, which generates the heat to vaporize the liquid that's inserted. So when a person's using an e-cigarette, what they do is they inhale and they hold the fire button, and that sends power to the coil, and that causes it to glow red hot and vaporize the e-juice or the liquid contained within the wick that's passing through it. And as you can see, that's what a coil looks like. A study conducted by the US National Library of Medicine showed that in the right wet and dry conditions and the effect of applied power, an e-cig coil can range in temperatures from 145 degrees all the way to 1008 degrees. So we're seeing that one of those coils can get hot enough in the right conditions to auto-ignite some of those components, or some of those components of the liquid, sorry. Although the standard operating range should be around 250 to 350 degrees C. So what we're saying here is even without a fault on the unit, an oxygen patient can create the perfect recipe for a serious fire-related incident. And as you can also see here, if a foreign object was to go down into the drip tip, that causes something called coil spit, which again can cause a flash or a spark from the e-cigarette itself. And we all know an oxygen patient, when they're oxygen enriched, it does render the fireproofing in the clothes useless. They are far more likely to catch fire and to have a serious incident. Next slide, please, Claire. Another popular e-cigarette culture now is to, when they clean it, is to ignite the e-cigarette and burn the old wick to remove the cotton. So again, if we've got an oxygen patient who's doing something like this and they haven't turned their oxygen off and they've not had the 20-minute break and they are enriched, it's a real recipe for something to go horribly wrong. And as well, so modern e-cigarettes now, they're becoming more high powered, they're getting a higher wattage through them. So 90% of explosions do happen with a modded e-cigarette. And again, this is just more recipe for disaster when we have an oxygen patient on an e-cigarette. Another cause for concern is this wide availability now of unregulated batteries and battery chargers. A lot of non-CE marked equipment. It's not been through any rigorous testing, and it's quite widely known that this equipment in the home, it can burn, it's cheap. If it's not manufactured to a high quality, we can melt plug sockets, and these batteries, again, they can explode. So we're seeing a real risk in the home if people aren't buying the correct equipment. So please do warn your patients who vape against unregulated products. They do increase the safety risk. Here's an image from an actual e-cigarette explosion. So not only that itself, but if you can imagine now with an oxygen patient, that will be exaggerated quite significantly. We would see facial burns, we would see I'd certainly expect to see a hospital admission. We would see the local community at risk as well. Next slide, please, Claire. Yeah, so you can see there, again, just what happens to the batteries and the person. So the risk is very real. The risk is there. But what we're not saying is that people should not use e-cigarettes. We recognise that they're widely used to help smokers quit. Nearly 2/3 of current vapers are ex-smokers, and that's around 65% of the vaping population. As prescribers of oxygen, we feel it's important that you know the risks and keep your patients safe by advising them to reinforce safe vaping, and they should be used as an important tool for smoking cessation. But there's still that carried risk, and we need to know that patients are going to use their e-cigarettes safely. I think that's all from myself, unless anyone has any questions, any comments, concerns. Hi, Linny.
Thanks, Niall. Ooh, right, so Linny, do you want to go first as you're at the top of the list?
Thanks. That was really interesting. Thank you for that. I'm just wondering if we're any closer to finding out what potential harm or damage the smoke can do to lungs yet. And I've heard they contain traces of copper and other sort of metal elements. And how are we looking at a future wave of lung damage through e-cigarettes, or is it far safer than, I mean, it is safer than inhaling smoke, I get that, but do we know any more about the potential harm it could do?
I personally actually don't. I've only heard of one condition in the local news, and that was something called wet lung. And actually, oh, forgive me, I should have done some research on that. I apologise, Linny. Can I get back to you on that one?
Yeah, that's fine. Thank you.
Sorry.
No, that's fine. Thanks.
That's okay. So just on the back of Niall, there is some, as you mentioned, Linny, there are some research going on in the background with the thought that the coil is made out of copper, and that patients potentially inhaling copper. So there is some papers out there, but yeah, that's something that we can have a look at, Niall, and maybe share,
Yeah.
send out to everybody.
Thank you.
Thanks for saving me there, Julie.
Right.
Wendy?
I'm just going to be cheeky now, Niall. Your images and things, can I actually use in the clinical network? Can you email those?
Yeah.
Please.
Of course you can, Wendy.
Thank you, Niall.
Oh, we got a paper.
See.
Okay. Yeah.
Thanks, Elle, for that, sharing that. Is there any more questions for Niall?
Oh, Eleanor.
Yeah, Elle, hi.
Hi. Yeah, with obviously saying, obviously giving safety advice regarding vaping and oxygen. I know obviously we have to be careful and balance up the need and the risk, but I wouldn't imagine I would ever prescribe somebody oxygen that was currently vaping, and just obviously going through the safety of making sure that they're 20 minutes clear before they vape or whatever. I would imagine it would be a straight no, the same as, you know, I know we have to balance it up, but I don't know whether it's a bit muddy. I don't know.
That'd be a valuable thing to have in the policy that we're sort of looking to discuss, wouldn't it?
Yeah, I think as Niall has said, Elle, I think that, you know, we need a proper policy, smoking policy, which includes obviously vaping across the East Midlands, so everyone's doing the same thing. And I know that there's always been the policy in Nottingham City that patients who smoke aren't prescribed oxygen, they have to be smoke free for 3 months. But, you know, where is that actually written? And I think it'd be really interesting when we get together to actually have this discussion, because I know that some smoking teams do actually have in the past prescribed vaping equipment for patients to help with smoking cessation. But as it's already been highlighted, there is new research now saying that actually, you know, how safe is that? And are we going to have a whole generation of young people growing up with lung disease because they're vaping? So I think, again, that's something that we really need to be looking at when we're doing this policy.
Thank you.
That's okay. Any more questions for Niall? No.
Thank you for listening, everybody. Appreciate it. Cheers.
Thanks, Niall. So I'm going to hand over now to Josh, who is going to talk to us about the Fire and Rescue Service and our collaborative working. Thanks, Josh. Over to you.
Thank you. Hi again, everyone. Just a few slides about what we do as a fire service, and then the link to incidents and people using oxygen. So I've got in the year, forgive me, the figures are slightly out on this one, but I've got the correct figures. So in the year 2021, this is just in Derbyshire, we attended 458 fires in houses or flats or where somebody lives. 414 of these were accidental and 44 were deliberate. And in that year, there was 5 preventable fatalities due to these fires. The severity for the fires was 39 high severity fires, which means that somebody was injured or died. Just as a more of a nationwide perspective, fires are going down. So in 2003 to 4, there was 170,000 fires that fire and rescue services attended in England alone. So that's 45 fire and rescue services. But 2018 and 19, that went down to just under 60,000. So it's an average of 1,300 per fire and rescue service in the year. So in Derbyshire, we're doing quite well, so we're at 458, so quite a low number compared to the national average. So what our goal is as a fire and rescue service is to reduce ADF, which is accidental dwelling. Our community safety officers.
Sorry, Josh, we keep
crews.
Josh, sorry, we keep losing your voice. I don't know whether it's because you're too far away from the mic or whether it's connection issues.
Josh, it might
think it's-
improve if you try switching your camera off. That can improve audio sometimes. Much as we'd like to see you.
I'll give that a go and see. Hopefully.
All right, thank you.
I'll give this a go with the camera off and see if it goes better. So yes, our goal is to reduce accidents, reduce death and reduce cost. They're all linked together. Obviously, if we can reduce the fires, there's no chance of injury or less chance of injury, less chance of death. And these all saving costs where we can put this extra cost or this money saved into more prevention activities and getting out there to the more vulnerable within the community. Next slide. Is that better on? Can you hear me more now? Yeah.
Yes, thanks, Josh. Yes.
So next one again. Yeah, so the risk of fire in homes, there's different ways of risk. Which the well-being, depending on the person's well-being, that could provide a risk. The behaviours in the place. So to go to the next slide, we'll explain a little bit more. Okay, so the well-being, so that's got a link to fire. So people with less mobility, any impairments, mental health, age, and medical conditions. So these have all, from statistics, we do know that these do have quite a big effect on whether a person's susceptible to a fire, and more importantly, susceptible to injury or death from that. So we'll look at data which is explained a little bit more in the next couple of slides about age and things and how different parts of our life become more. Behaviours for people, obviously smoking is an inherent risk in the home. Drinking, internal doors, candle use, and unsafe cooking. The majority of fires in the home do start in the kitchen, but we do see a lot of vulnerable people with substance addictions, alcohol, drugs, and things. That in the home that are less mobile, we do see an increase in fires within these properties. The place of the lack of working or appropriate smoke detection, so that obviously won't stop a fire, but what that will do is decrease the chance of that person being a fatality by allowing them time to escape the property. Lack of internal doors, so that's about reducing the amount of fire spread within property. So when we go into houses and tell people about fire safety, tell them everything in the world, tell them gold standard, switch everything off, but there is always that chance of fire can start. So a big thing we say, and we'd always try and encourage other agencies to say, is closing internal doors will help keep fire within. It doesn't have to be a fire door. A normal household door can hold fire back for about 30 minutes to escape the property. Clutter and hoarding. Clutter and hoarding is quite an increasing risk that we're seeing. We a small percentage of hoarders, and these hoarders a high risk of fire and a high risk of dying within a fire. So we work quite a lot with hoarders and people with a lot of clutter. We do things like provide skips to get rid of some of the stuff. We work with other agencies such as Healthy Homes to get these houses cleaned up and make them a bit more habitable for people. Electrical and gas maintenance, again, a lot of people wouldn't, well, not say a lot, there's a majority of people that tend the electrics checked, the gas check, but there's a lot of people that don't, whether that's for financial reasons or it could be, because of their well-being, to come in or they can't let people in. And then lack of cleanliness. Again, it's through the house, it links back to hoarding as well, and clutter is, if somebody's got an issue where they can't get out of the house because of mobility, they can't put the rubbish in the bin, so they tend to you can leave it inside, which then creates a fire risk. Next slide, please. So this is one where I think there's about 20 clicks to it. So this is kind of a flow of so along the bottom it's the age, and it's not say 100% accurate to say at this age that you're at this risk, but so along the bottom is age, and then along the vertical line is the risk. So starting at the top at low risk, moving down. So as you start on the left at a young person, so let's say from birth, they're generally at low risk, got a loving family. We know newer parents are quite safe. We know that you know they try everything they can to ensure that they look after themselves and the child or children. As they get a little bit older, it levels off a little bit, just because we know children do a bit of a fascination with fire, and they can start experimenting with things. But then when they go to school, they're at less risk there because they're at school, being occupied in the day. They're occupied at night with their parents. I'll explain the red rings once I've gone through the ages. So as they get a bit older, they go through uni. Once they get to uni, the risk increases. So they start drinking, is it freshers' fair, they call it now, freshers' fair. So they start drinking, start cooking, you know, they go back to the halls or to the home and start cooking whilst impaired. So the risk does increase. But then once you finish uni, potentially get a job, the risk levels out. It goes a bit lower, levels out because they're occupied at work. Then they have children, so that risk goes all the way back down again because they're now looking out for the welfare of that child. Then as they get even older, the health starts deteriorating. So going back to the previous slides about people's health and well-being, you know, we see a decrease in health and well-being with people as they get older. So that inherently puts them at more risk of fire. And as they get older, get more frail, and this again leads to people that may not leave the property, that may start hoarding, and then as they get even older, the risk does increase, and you know the very bottom peak, you know, is anything really over 65 and 80, because they are the most common or the most highest risk of fire, according to data over the years. And then it goes less risk as they get even older, just because somebody that is, let's say, 80 plus, 90 plus, not always, but can be more frail, so they can't use things like cookers, and you know they can't use things that would start a fire. That, you know, they're in what you call them, like hospitals or homes and things. They can be, so they're at less risk of fire then. So the red circles along the line, of these are where we've realised that these are the best points to try and educate. So let's say the first one, so we visit schools, talk about fire safety, talk about means of escape, and quite interactive with children. And then we go to the opposite one, so the very far one on the right. So we have, you know, in Derbyshire, anybody over 65 currently gets a knock on the door from us, and that's our way of engaging with that person. Next slide. So our safe and well check. So when we go and do our safe and well checks, which it used to be called a home fire safety check, however, it changed a few years ago from a government perspective. So they wanted us to not just look at fire, they wanted us to have a look at the broader aspects of people's well-being. And each fire and rescue service almost given a list of things to look at. And in Derbyshire, we chose falls. So we do a falls risk assessment, You know, primarily, you know, we are the fire service, so we look at fire. However, we do that extra thing. So other fire and rescue services around the country do various things. Some others do falls, but they'll look at something different. So when we go in the home, we give fire safety. We walk around the home with the person, pointing out any potential fire risks or any hazards and ways to mitigate them risks. Our difficulty is people in their own home. We can only advise them, and if something's screaming out to us that's going to set a fire tomorrow, if they don't want to change it, they won't change it. Our community safety officer can be quite persuasive, so they'll try and talk to them, explain to them the risks and how to mitigate these risks. Escape routes, we talk about escape routes, how they and the families can get out of the house should a fire occur, because we always plan for the worst. So we say, should a fire occur, this is how we can get out, this is what you should do, these are the best actions you can take. We carry out a shortfalls risk assessment. This is just a number of questions that we ask them about medication, about if they've had any falls in the last 12 months and things, and then from that we then pass that information over to partner agencies who can then get involved. Complete a first contact form that enables us to signpost. So in the county, we use first contact. In the city, it's slightly different. But this is just our referral pathways to look at literally anything that person could need a little bit of help with or is unsure of, and that can be anything from home library services to fraud prevention, home security. And we've got such a big list of partners that we work where we can try and improve that person's well-being, their life. Properties that don't have any smoke detectors or that do have them that are quite old, we do fit free of charge our smoke detectors. They do have a 10-year battery life on them, so it's a sealed unit. So gone are the days where you can go to a property where they've got a smoke alarm, but they take the battery out because they burned the toast. So these new alarms that we give them, they stop them from doing that as a sealed unit. For those with sensory impairments, we do alarms for people that may be deaf or hard of hearing. These alarms consist of a normal smoke alarm with a Bluetooth link to a big strobe light and then a pad that goes underneath the pillow. That if that fire alarm was to activate, it'd vibrate and it'd wake them up. And then portable misting system vulnerable. So when we identify somebody that is extremely high risk of fire and more so high risk of dying within that fire, we can fit what's called a portable misting system. So for an example, somebody that's not mobile, heavy smoker, the clear signs of cigarette burns on themselves, the floor, the carpet and things. That person's high risk of fire and high risk of not being able to escape. So we fit these portable misting systems, which is just a big retrofit unit that goes in the property, in that room. It's got 110 litres of water in it, and if that system senses a fire, it does two things. First thing is it activates that water into the room to hopefully put the fire out, and the second thing is it automatically lets us know. It's got a SIM card, so it lets us know that there's been a fire. So there's no 999 call needed, and we automatically know, and then our control will automatically mobilise fire appliances. So we've currently got about 62 in Derbyshire. We are the lead in the country for portable misting systems, so all other fire and rescue services come to us for them or for advice about them. Next slide, please. Yeah, so how we work with BOC. So we get data from BOC about home oxygen. So when oxygen is put into a property, when it's taken out, data, we put this on our mobilising system, so that if for any reason that we are called to an address, using the information from BOC, it will automatically put a notification to the crews that are attending that there is oxygen present in that property. Two reasons. One, so it gives us a little bit of an idea. So if there is a fire in that property and it is confirmed, we know there's oxygen in there, so that could exaggerate the fire more. So we've got to be wary of that. But two, for firefighter safety, compressed gas in there. So, but that automatically comes on the system when we get the information from BOC. With regular catch-ups with BOC. So Pam, they work together a lot to set up reporting, so we know how many properties in Derbyshire have got oxygen, when it's coming out, when it's going in, and then we can follow these properties up with safe and well checks. So any safety advice that we give, so they're quite highly trained in the effects of oxygen and fire, the effects of fire spread in the home. So they give a lot of advice to the people in properties, not just about preventing fire, but how to escape. And the big part of what we do is, again, is signposting to partners. And what we're trying to do is get all the partners. So for yourselves that go out in the community, the community nurses and things that go out, is signposting to us as well. Because there is a lot I know about that kind of slip under the radar. So it's important that we use partners such as yourselves, the police, adult service, through, so that if there is anybody that people think are susceptible to fire, let us know and we can get in there and try and give us some advice. Next slide. Oh, that's it. Questions? Could you hear me better that time?
Thanks, Josh. Yeah, you were a bit in and out, but I think I think everyone sort of got the gist of what what you were saying, and obviously being able to read the slide. So that's really useful. Useful information for everyone to understand that we do all work together, and it's shared information is really, really important. Does anybody have any questions for Josh?
Julie, I was just going to answer, it's probably relevant to everyone. Catherine has put on the chat about an emollient question,
okay,
to do with, flammable creams. Now, I always say that you have to do a risk-benefit approach. So, for example, I get clinicians to discuss with the pharmacist, is there a safer alternative? In some cases, there won't be, and you have to look at whether, that cream is still the essential cream. For example, a patient with skin cancer, there may not be alternatives. So then we look at, are they washing their bed linen at hot wash? Are there any times when they can be off of the oxygen? But I'm really sorry that there isn't a kind of a consensus on safe alternatives. It's very much on the skin issue at the time, speaking to the pharmacist, speaking to the GP, and I know that's probably not what you want to hear. I don't know if there's anything else anyone would add to that.
We've got a question from Pam Tyndall.
Hi, good morning. Pam Tyndall from Derbyshire Fire and Rescue Service. So it wasn't a question, it was just something I picked up really early on when the doctor was talking to us about the incident with the chap that had the home oxygen, and Lady from Bock had said that the incident of fire occurring was unbeknown to them. So it was just to let you know that in Derbyshire, what we're trying to set up at the moment is two-way incident reporting. So Bock already send us the information about where the oxygen is being placed and removed, but we are now also trying to use that information to set up a report that goes back if we do attend an incident of fire, BOC will be informed of that on a daily reporting at 6 o'clock in the morning, for example. So that's flagged up and you're made aware. So we're just in the middle of just, dotting the I's and crossing the T's on the information sharing agreement. But if any partners across the network wanted to have a look at that and share it, then that's there as a resource for everybody to access, and you can contact me through Niall. Thank you.
Thanks, Pam. We've got Wendy.
Yeah, so this wasn't my thing, but thanks for that, Pam. One of the things that Dab has always been very engaging with East Midlands. The original MHORT was actually done with Derby Fire Service. So it would be useful if we can actually get the other fire services across East Midlands on board to work alongside Derby, so we can have all representation there, because it would help moving forward, because otherwise it becomes a postcode lottery. The original reason for my hand up was Catherine. The evidence, I was part of a working group a couple of years ago, working with fire services and clinicians and tissue viability nurses and everybody, including the coroner, regarding emollient. There is no paraffin-free emollient. If somebody needs an emollient for a skin problem, it is about going for the lowest amount of paraffin possible. And as has already been said, it's about risk assessing then the whole situation really. But always go, if somebody has to have it, go for the lowest emollient. And I know Lynn put in what we're actually advised as first line in knots, but these things change constantly. So just go for the lowest, either none at all if they don't actually need it, but if they do need it, go for the lowest amount of paraffin you can find. And the oatmeal ones generally are the lowest ones. So there's not a black and white on this. It is based on that individual patient. But if you need anything, by all means, drop me an email.
Thanks, Wendy.
Just to touch on your point there, Wendy, I am working in the background to sort of get BOC integrated, like with these relationships with the fire service. So Northamptonshire have been absolutely fantastic recently, and we've got a guy called Anthony who works for BOC, one of my technicians who we're growing. He's already been to visit Pam's team, and he's now going to visit all 22 fire stations in Northamptonshire. We're doing equipment demonstrations. We're doing, Q&A sessions with the fire services. It has been a mixed reaction at the moment, but we are working to push that. So that's not something that's just going to come to a standstill, certainly from my end anyway.
That's brilliant. So that's probably something. Can we actually join forces now? Can we have a chat at some point outside of this meeting just to sort of discuss that and maybe put in the fire service network together so we've got contact?
Yeah, absolutely. That sounds fantastic. There are plans to get us onto like the local community service managers meetings as well. I think cross reporting and talking to each other is really valuable. And you're right, we don't want it to become a postcode lottery.
Thanks, Niall.
No worries. Thank you, Wendy.
So is there any more questions? No. Okay, so can we have the next slide? Thank you, Claire. So we're nearly at the end. It's now 10:25, so that's gone really, really quick. Thanks ever so much for everyone for coming today, and thank you very much for our speakers for sharing their information with us as well. Safety is really paramount with us at BOC, and as the Siri highlighted and Dr. Booth highlighted, it's not always obvious when somebody smokes. And it's really looking at the additional things that you might pick up on when you're going in to visit patients' homes. So is there a cigarette lighter hanging around, or an ashtray, or is there a smell of smoke? Anything like that. Every smoking incident should always be investigated and shared with us. And you can do that by either picking up the phone and speaking to PSE, or speaking to me or Claire, or dropping us an email, and we can highlight that and share information together and try and support you with that as well. And as it's been highlighted, we really do need a comprehensive smoking policy across the East Midlands so that everyone's singing off the same hymn sheet and everyone's working to the same guidelines to try and reduce smoking related series and preventing incidents from happening earlier on. So again, I'd like to thank everybody for coming today, and yeah, we'll pick up some of these things as well at the East Midlands Clinical Network meeting. So look out for your invite for that. Wendy will send that out to you. It looks like it's going to be beginning of November now. And if anybody wants to share the smoking policies that they have in their organisation at the moment, then please, send it to myself and Wendy and Claire, and then we can use that as a basis. So thank you very much. So have a lovely rest of the day, and we will speak to you all very soon. So take care, everyone. Bye.
Bye.
Thanks. Bye. Thank you.
Thank you all. Bye-bye.
Thanks.
Thank you.
Thank you.